So hi, my name is Mamas Mamas. We're at the American Heart Association in Philadelphia, and today my guest is Dr. Van Spall from the University of McMaster in Canada, and we're going to talk about the PACT-HF trial. So this was a really interesting trial, so why don't you tell us about the outline of the trial?
So PACT-HF was a stepped wedge cluster randomized trial in which we aimed to implement evidence-informed services in our publicly funded healthcare system. We started with a network meta-analysis that demonstrated that nurse home visits and heart function clinic visits decreased readmissions and death among patients hospitalized with heart failure. And we recruited 10 hospitals across the province and enrolled patients who were admitted with the most responsible diagnosis of heart failure, and delivered these services to them, titrating them to risk.
Yes.
And we found that the services that have been shown in clinical trials to be effective did not work in the way it was intended in our healthcare system.
Yes.
So we found no benefit to the primary endpoint of all-cause readmission, emergency department visits, or death.
Yes.
But we presented the sex-specific outcomes at this meeting.
So that was a very interesting presentation. So I attended the late-breaking trials, and I saw that you did seem to see an interaction by sex.
That's right. So while the overall outcome was neutral, we found a differential effect between males and females. While males did not derive any benefit in terms of the hard clinical endpoints, we noted that females had a significant reduction in 6-month composite all-cause readmission, emergency department visits, or death, and that this persisted throughout to the end of the one-year follow-up period.
I mean, why do you think that might be? Why do you think that there is this? Because we also saw this in Paragon as well, this sex difference in outcomes. Why do you think?
I think there are many biological differences that explain the differential impact between sexes seen in Paragon. I think our work was healthcare services, and it is possible and perhaps even likely, based on other observational studies, that females are more adherent to therapies and also have a better ability to provide self-care and manage their heart failure. And it is possible that these factors impacted their outcomes following the healthcare services that we delivered.
I mean, one of the very interesting things that from your late-breaking trial presentation was really around the design of your study. So you decided to look at all-cause hospitalisation rather than heart failure-related hospitalisation. And certainly from the work that we've collaborated in terms of primary heart failure, more than 50% are non-heart failure admissions. In terms of secondary heart failure, the number goes up to 70%. So why did you choose all-cause hospitalisation?
That's a good question. So this work was integrated knowledge translation. And the philosophy is that we engage decision makers in our healthcare system, as well as patients in the design of the trial. So to the decision makers across the province, the cost implications of an admission persist regardless of the underlying cause. And to patients, the burden of hospitalization exists regardless of what they are hospitalized for. So both patients and decision makers wanted us to choose an all-cause clinical endpoint, and we incorporated their input into this trial. I would also say that many of our heart failure therapies target CV death and heart failure hospitalization. Those endpoints are more sensitive to heart failure-specific interventions, but the burden of heart failure, as you alluded to, extend beyond those small endpoints because they don't account for the vast array of causes that people come into the hospital for. So I do believe that the endpoints were clinically relevant and also relevant to patients. And for that purpose, were chosen for the trial.
No. I mean, congratulations. I thought it was a really superb presentation. And I think, looking at the subgroups, whilst, from a purism perspective, certainly if the primary endpoint was negative, these can only be considered hypothesis generating, will certainly help provide insight into other work that we want to do and how we treat this complex management of patients. So
absolutely, it certainly calls for more research and understanding into why these differences exist and how we need to tailor therapies to males versus females.
Yes, a lot more robust work is needed. Thank you.
Absolutely.